Let's proceed to the next exciting session. It's going to be a panel discussion on acute pancreatitis. We call upon the panelists onto the stage, Dr. SUDIR, Dr. Jagan, Dr. Rabindranath, Dr. Balabaskar, Dr. Balamurugan sir. I call upon the moderator of this panel discussion, Dr. Mohanraj sir, to be on the stage.
Like in past discussion, we have seen ulcerative colitis, which need a team. Likewise, pancreatitis also need a team. So we have a wonderful team here, like with a physician, with a surgeon, with a radiologist, with an intensivist, and a medical gastroenterologist. Today we are going to a common clinical cases which we usually see. This is one of our case present to our hospital. We have 51-year-old female present, who is symptomatic for past 3 days, present with the abdominal pain, epigastric and right upper quadrant pain, continuous pain, increased with food intake and deep inspiration, radiating to back, associated with vomiting, fever, and patient is having yellowish discoloration of eyes and urine. There is a history of itching is there and clay color stools are there. No other significant past history or present history. Patient is having known diabetic for past 7 years. No other significant history. In this situation, I will ask a physician, Dr. Balamurugan, when you see such patient, what is your differentials?
Good afternoon all. It's a middle-aged female, diabetic female, presented with a 3 days history of upper abdominal pain, epigastric and right hypochondrium, along with jaundice, passing clay-colored stools, and itching. So, my first DD will be obstructive jaundice, as evidenced by upper abdominal pain, passing clay-colored stools with itching. But here, patient is having fever also, so maybe coexisting with the cholecystitis. The history is very short, 3 days. So it could be calculus cholecystitis with the cholelithiasis. The another thing is patient is having epigastric pain, which is radiating to back. So it may be complicated with the acute pancreatitis. So my first DD, acute calculus cholecystitis with the cholelithiasis, complicated with acute pancreatitis. Second DD, sometimes in isolated acute pancreatitis alone, if the head of the pancreas edematous, it may compress intrahepatic portion of CBD, that may cause transient cholestasis. So second DD will be acute pancreatitis with the transient cholestasis. Third, this diabetic female presents with the fever, abdominal pain and jaundice. So it could be a case of acute viral hepatitis. Then fourth, epigastric pain aggravated with vomiting after food intake and jaundice. Sometimes complicated peptic ulcer disease or DU perforation. That also will be a fourth DD.
Yes, like he said, like we also thought of same thing only. Then on examination, patient is found to have a trick and there is a tenderness in the epigastric and right upper chondrum. And like this thing, what investigation you will order? Dr. Balamurugan?
Diabetic female will start with basic blood investigation, CBC. It will give a lot of information regarding hemoglobin, hematocrit, and leukocytosis, or whether it's associated with thrombocytopenia, thrombocytosis, then random blood sugar, renal function test, liver function test, CRP, then radiologic investigations like ultrasound or CT if needed.
Okay, like we have done the investigations, what you have listed. Can you interrupt the investigation?
Here, hemoglobin is 12.6, total count 13,800, so mild leukocytosis is there, platelet count is normal, hematocrit is 52. When you are dealing with the case of any acute cases and hematocrit is more than 46, it indicates patient is having hemoconcentration. Blood urea nitrogen is 28, slightly high, creatinine is 1.2, amylase is 1420 and lipase is 1200, CRP is 28, LFT total protein 7.6, direct 4.3, and AST ALT elevation is there, ALP is 356, GGT 546, total protein 6.8, allopin 3.6. So this patient is having, as I said, it's a case of obstructive jaundice with acute pancreatitis. Amylase lipase are so high, and patient is having hemoconcentration also.
Yes. Like LFT clearly shows patient as having cholestatic jaundice. And do you order any imaging?
Yeah, definitely, sir. With the ultrasound, if it's not evident, then we can go for CT. Here, the ultrasound shows bulky pancreas with the peripancreatic fluid collection, multiple gallstones multiple gallstones with the largest size of 1 centimeter, cholelithiasis in distal CBD, measuring 8 millimeter with upstream dilatation of and IHP dilatation.
Okay. Like after seeing all these investigations, Dr. Balamurugan, now what is your diagnosis and why do you say so?
My first DD, as I said, it's a case of acute calculus cholecystitis with the cholelithiasis complicated with acute pancreatitis. Pancreatitis because of gallstones.
Yes, like for acute pancreatitis to be diagnosed, 2 out of 3 criteria should be there. The patient is having typical abdominal pain and amylase lipase are elevated 3 times of the upper normal limit. With these 2 things, we can diagnose the acute pancreatitis, and if something is not there, we can go for an imaging. And acute pancreatitis is the severity is graded like mild acute pancreatitis, moderately severe acute pancreatitis, and severe acute pancreatitis. Dr. Ravi, what etiology you are suspecting in this case, and why do you say what investigation you will order?
So as we can see, that patient is having an biliary pancreatitis, acute biliary pancreatitis. It is because of the stone that is in the CBD, that common bile duct, that is coming and obstructing the pancreatic duct, causing this pancreatitis. So the investigation I would do would be like in a center of expertise, diagnostic endoscopic ultrasound. In general, MRCP is more widely available. In this case, I will go for MRCP.
Yes, this patient is diagnosed of gallstone pancreatitis because serum ALT is more than 150, which is more specific and positive predictive value of more than 96%. And likewise, like Dr. Rabindranath told, we did an MRCP, and the MRCP clearly showing stones in the terminal bile duct. And coming to the etiology of pancreatitis, hypertriglyceridemia, pancreatic divisum, autoimmune medications. Most common etiology is alcohol and gallstone disease. Like in Western, most common is a gallstone disease. In India, most common is alcohol. Like Dr. Balamurugan, what other etiology work you do in this case?
The first most common cause in India will be alcohol, followed by gallstones, followed by hypertriglyceridemia. Then other uncommon causes, cystic fibrosis or hypercalcemia or autoimmune or drug-related. Here, in this case, we can order for fasting lipid profile, serum calcium. If the hypercalcemia is there, we can rule out the causes for hypercalcemia, like ordering parathyroid hormone, vitamin D, TSH, and we can inquire about the drug history. And
okay, thank you. Like Dr. Balabaskar, what are the scoring system you know how to use to triage the patients?
Yes, good afternoon. So after diagnosing the AP, this patient needs to be triaged so that the patient can be admitted in a monitored zone. So this is based on, to detect the severe AP. Severe AP has more complications and needs aggressive management. To detect the severe AP, scoring system is important. We have organ-specific Ranson's criteria, Glasgow score, and revised Atlanta classification, BISAP, HAB score, and non-organ specific is Apache 2, that is more reliable, which has more negative predictive value. And also, if you want to check the biomarkers, CRP and IL-6 is also helps to detect severe AP.
Yes, can you say about something about the Marshall scoring system?
Originally, Marshall scoring helps to detect, helps to identify the organ failure means it goes to severe acute pancreatitis. Here, main three organs were stratified, mainly the respiratory system, the renal system, and cardiovascular system. Only one criteria were taken: respiratory system, PF ratio; renal system, the creatinine value; and the cardiovascular system, the systolic BP. So for each one, they allotted a score of 0 to 4. When the score is more than 2, they consider as an organ failure.
So more organ failure, more the morbidity and mortality.
Yeah.
So the patients need to be admitted in the ICU. And next is the bicep score.
Bicep, again, this is the easiest score, which has only 5 parameters. If the score is more than 3, it shows severe AP, severe acute pancreatitis. In resource limited setup, we can use bicep score.
Yes, simple and like it's easiest. Can you say about Charlson Morbidity Index?
Charlson Morbidity Index, this is one of the risk factor detection. So patient with mild disease having more comorbidities, with the help of Charlson Comorbidity Index, we have to evaluate the comorbidity index risk. If the score is more than 3, they have high risk to proceed to severe AP.
Yes, Charlson Index more than 3, high risk of severe pancreatitis. So combining biceps and Charlson Morbidity Index can improve the yearly risk stratification in biliary acute pancreatitis. Can you say about HAP score?
HABs, again, it carries only few parameters. One is the clinical one. On clinical, if there is gouging and rebound tenderness, and lab 2, only 2 lab values, creatinine of more than 2 and hematocrit of more than 43%. Score of 0 to 3, 0 is less risk and has good prognosis, only that much you can say.
Yes, this score is useful with limited settings, where with the simple investigations, which patients you need to take care more, you can easily identify this kind of patients. Like, is there any other parameters like simple blood test or something? You'll see, you will admit the patient in intensive care.
Yes, there are tests are there, and after stratifications, those who have risk factors like the elder peoples with the age of more than 55, BMI of more than 30, obese people, and people with patient with altered mental status and comorbid disease. Comorbid, again, we told already, we use a Charlson Comorbidity Index. And also at the time of admission, patient with SIRS or persistent SIRS, those who already admitted in ward, persistent SIRS, and with organ failure and lab values, hematocrit of more than 44, burn of more than 20, high creatinine value. So these are the predictors. Based on this, we will admit the case in ICU. They need to be vigorously managed.
Yes. Like, new thing is there, like now they are also checking interleukin 6. By combining interleukin 6 and CRP, we can assess the severity. Coming back to the patient, we have done investigations on hematocrit, blood urine nitrogen, serum creatinine serially followed, hematocrit, blood urine nitrogen serially decreased, and we made a diagnosis of acute pancreatitis moderately severe with gallstone related with cholangitis. And now, what will you do, Dr. Rabindranath?
So this case is a case of severe acute pancreatitis, moderately severe. See, in the pancreatitis cases, as we know, that first part will be the IV fluids. Patient usually will be kept in NPO on the initial day of presentation, and then comes the pain management, IV fluids management, and adequate nutrition. When to start the nutrition, what painkillers has to be given, whether antibiotics has to be started or not, whether endoscopist intervention has to be done in this patient or not. We'll see that one by one. So first comes the pain management. If the patient is having severe pain, what we initially follow is round-the-clock paracetamol infusion, and then tramadol up to 8 hourly once we can give. The problem with the studies are, there are more studies regarding the opiates and NSAIDs. The problem with NSAIDs is renal failure and GI bleeding, and problem with opiates is ileus and then respiratory depression. So it has to be judged upon the patient condition on the day. Basically, what we prefer is to start with paracetamol round the clock, and then on and off fentanyl as required. In case of opioid intolerance or anything, we even use diclofenac as and when required. Yeah, there is we have to first assess in which stage the patient is presenting. If the patient is having severe pain, straight away going to fentanyl patch or fentanyl infusion round the clock in an ICU setup is also been recommended. So that's what judicious use of analgesia is important. The first point is like patient is more, he's not bothered about the organ failure or the SIRS component. He is bothered about one thing, that is you are keeping him in hungry status, and the second thing is pain. So first we have to take care of the patient and then the patient parameters. In that way, analgesics plays a role. So there are multiple studies whether to paracetamol or tramadol, and then there are no significant difference. The round-the-clock paracetamol is equivalent to the tramadol. And pentazocine, in which places it is freely available, that has been studied like pentazocine is better than diclofenac. But in India, in an AIM study, they say diclofenac equally does with pentazocine, and they prefer not to give pentazocine in the initial track. And that's what. In our setup, I would suggest when to refer for a case whether it is worsening or not. The patient is having a SARS more than 48 hours, if there is an organ failure, if he is not responding to the initial analgesia, it has to be referred to the center of excellence where it can be dealt, and there is more volume of pancreatitis support. So then from there we can decide about whether to add fentanyl or round-the-clock tramadol, etc.
Yes, like paracetamol and weak opioid we initially start, and NSAID on and off, and we'll escalate if the further pain we go for an opioids. Like Dr. Balabaskar, what is patient controlled analgesia?
Patient control anesthesia is the patient can able to titrate the medication like analgesic. It is like a machine, computer programmed machine, where we have to load the analgesic, more of opioids, so that when the patient feels pain, he himself can take the medication.
Yes. Why do we need a patient control analgesia?
So actually, that previously, if the patient got admitted, the nurse they have to provide the analgesia. Here the pain is very severe, so the patient can able to do them on his own.
Yes, like to save time and those with severe pain, we can use patient controlled anesthesia. This is the technical design of patient controlled anesthesia, where this is the activation button is there, and there is a microprocessor and drug concentration and incremental size, and there is a locker, interval timer locker is there. So patient can't continuously push the drug, and the infusion pump which is readily connected to the IV line. So whenever patient feels pain, he presses the button, and the fixed dose concentration by which the physician has prescribed, the drug automatically goes to the patients. It's now getting popular actually. Coming to fluid therapy, Dr. Balabaskar, which fluid you give, how much will you give, when to give, and how to monitor?
So in acute pancreatitis is an inflammatory state, hyperinflammatory state, where there will be a much of vascular leak. Depending on the severity, the more vascular leak and the hypovolemia. The hypovolemia decreases the perfusion to pancreas itself and the wall depending on the severity. So here the fluid plays a crucial role in AP. So the preferable fluid is crystalloid. Among crystalloid, oral is better, and because NS has more chloride to prevent the disadvantages of hyperchloremia, oral is better.
Yes, like how much fluid? based on this waterfall trial?
So the fluid rate depends on the weight of the patient. Based on the waterfall trial, previously there was aggressive fluid management. There are a lot of applications after 48 or 72 hours of continuous infusion. So after this trial, the thing has changed. The thing has moved from aggressive to moderate aggressive, around 1.5 ml per kg per hour. It is a goal directed, it should be individualized and goal directed. If there is hypotension or shock at the time of resuscitation, we can use 10 ml per kg of bolus we can use.
Yes, fluid resuscitation will be useful when done in initial hours. Mostly our patients tend to present after 48 to 78 hours. That time we resuscitate, that will be not much useful. Like when to give?
So yearly as early as possible. 12 to 24 hours, fluid plays an important treatment, support treatment, even it decreases the mortality. And it should be monitored.
Like Dr. Ravi, how do you monitor the fluid therapy?
So fluid therapy in general practice, how we can monitor this by measuring general mean arterial pressure, and urine output should be 0.5 to 1 ml per kg per hour, and the hematocrit range should be 40 to 44. And there are invasive methods and non-invasive methods. Invasive methods is like central CVP line, but it is not okay in case of where the patient is intubated or when under ventilation. And then comes your arterial lines that will show your regular mean arterial pressure. And the non-invasive methods is like in ICU setups, you are going to have your, you can measure the IVC diameter. It's less than 1.5% or that more than 50% of deficit we can correct. And then comes the lung ultrasound, so that you can monitor the fluid overload.
Yes, like Dr. Balamurgan, why there is a need for fluid resuscitation?
Pancreatic patient mostly present with patient will be very anxious and the shock. Shock is very common with acute pancreatitis. Shock because of 3 ways of fluid loss. The one will be it's a retroperitoneal organ. So inflammation of pancreas itself will cause like a exudation of fluid into the retroperitoneal space. That will cause collection. That will be the cause for hypovolemia. The second will be increased formation release of kinin. Kinin is a potent vasodilator. That will cause vasodilatation as well as increased vascular permeability. That also will cause fluid loss. Third will be a release of proteolytic and lipolytic enzymes into the systemic circulation. That will cause shock. So these are 3 mechanisms involved in shock in the case of pancreatitis. So initially fluid resuscitation is very, very important to save the patient.
Yes, like initial fluid resuscitation reverses the damage, like it reduces the patient from going from edematous to necrotizing pancreatitis if it is done within first 24 hours, and it actually improves the microcirculation of the pancreas. Dr. Jagan, nutrition, when will you start feed and how will you feed these patients?
So nutrition wise, in mild cases we start within 24 to 48 hours. In severe cases we usually wait till 48 hours and then we start the feeds. Generally we prefer nasojejunal or nasogastric. If patient can take oral, that is very beneficial. Always avoid TPN. Whenever is necessary we can give, but mostly we will avoid parenteral nutrition.
Yes, like we usually start when the patient there is no pain or patient feeling hungry, that's a sign we should start the feed. Like regarding antibiotics, is there any rational evidence or current guidelines, and how will you do you routinely give antibiotics to such patients presenting with pancreatitis?
Routinely we don't use any antibiotics. Only if patient has severe pancreatitis with needs ICU admission and there is a strong suspicion of necrotizing pancreatitis, or if associated with cholangitis, we start with antibiotics. Generally we don't use it.
Yes, like when there is a proven extra pancreatic infection like lung or cholangitis, then only we start, or if there is a strong suspicion that the patient is having infected necrotizing pancreatitis, that time only we will use antibiotic. Routinely we don't use antibiotic. Positive cultures from the body fluids, presence of gas bubbles is an indication to start the antibiotics. Elevated level of CRP, WBC, Procal should not be used alone, should not be used as a biomarker to start an antibiotics. Balabaskar, if you suspect infected collection, which antibiotic you will prefer?
So if you have high suspicion of pancreatic, the necrotic pancreas got infected, the antibiotic which penetrate the tissue should be used. Usually the target is the gut microbial organism, and have to use empirically broad spectrum antibiotic. Choice will be cephalosporins, carbapenems, quinolones and metronidazole. If hemodynamically unstable, the preference should be the carbapenem.
Yes, like those, because pancreas is poorly perfused and it is resistant to pancreatic, most of the antibiotics are resistant to getting entry into the pancreas. So you wisely choose an antibiotic which penetrates the pancreas, especially carbapenems are most commonly used. Dr. Sudhir, what is the role of CT scan and when to do and how to do it, CT scan?
CT scan generally we will do when there is some diagnostic uncertainty or lipase amylase levels equivocal or sometimes unresponsive to treatment. Generally we should do after 3 days or 72 hours. Preferably contrast, CECT is preferable because through plain CT you can do calcifications and necrosis alone better, means gas bubbles and all you can see. In contrast CT you can see the better complications like aneurysms, pseudoaneurysms, thrombosis and everything.
Like why do you want to wait 3 or 4 days to a CT?
After 3 days only you can see the necrosis and everything.
Yes,
better.
like after 3 days only you can assess the exact level of pancreatic damage. So and you have to wait until 3 days, then only we should do an CT. Otherwise, in initial days, if there is any diagnostic uncertainty or failure to respond to conservative treatment or any clinical deterioration, that time we can do an initial CT. Like, what is the pancreatic protocol you will follow?
As routinely we will do plain CT and mostly we should follow arterial phase and the pancreatic phase, that is portal venous phase. Arterial phase within 30 seconds to rule out any aneurysms or as I said splenic artery or some aneurysms, and this portal venous phase, that is the best or single phase if needed. There we can see the necrosis and other things clearly.
Yes, like timed pancreatic protocol should be done. And what is the role of MRI in these patients?
MRI generally not needed. If at all means to look for the bile duct anatomy or small any hidden calculi, something means we can see. Even the hemorrhagic staging, those things on.
So like Dr. Rabindranath, when you do ERCP in this patient?
So as per guideline, it is like within 1 to 3 days of presentation. If the patient is presenting with acute biliary pancreatitis and there is worsening WBC count, worsening sepsis component, worsening rise in bilirubin and ALP or GGT levels, we will be prefer doing ERCP. That doesn't mean that every patient presents with a biliary pancreatitis requires ERCP in the presentation itself. The patient can be stabilized, patient even can be undergo this cholecystectomy in that admission or the next admission and followed by ERCP is also wise. But in our setup, most of the time the patient present with cholangitis and worsening jaundice, we do ERCP within 1 or 2 days.
Yes, like doctor told, like if the patient is having cholangitis, it should be done on first 1 to 3 days. Without cholangitis, we can wait. This is an MRCP, and like we did an ERCP and we did stone retrieval and we did stenting for these patients. Post ERCP, patient improved symptomatically, tolerating oral feeds, vitals stable and discharged. 2 weeks later, patient presented with severe abdominal pain, nausea, reduced food intake, breathing difficulty and fever. So, Dr. Balamurugan, what do you consider now?
In this case, Cholecystitis can occur recurrently. So first DD will be acute cholecystitis. The second one is acute pancreatitis. There will be two phases: early phase and late phase. Early phase of pancreatitis already recovered. So patient may have developed late phase complications like peripancreatic fluid collection with the secondary infections. The third one will be pancreatic patients are more prone to develop pancreatic diabetes. They may present with a diabetic ketoacidosis also. So these are my TDs.
Yes, like we did investigations which showed total elevated total count, and amylase lipase is normal and CRP is same, and bilirubin is significantly reduced, and patient is having sugar of 561 and procalcitonin of 23. What investigation next you will do?
Here LFT is normal, so it's not a case of not a case of cholecystitis. Sugars are so high, 561. We don't know about ketone status. Procal is 23. Amylase lipase is normal. It will be normal in late phase of pancreatitis. So it could be a case of the counts also high, 17,000. So it could be a case of peripancreatic fluid collection with the secondary infection, along with diabetes, new onset of diabetes.
So already no patient is known diabetic.
Sorry, known case of diabetes.
Yes, the blood ketones positive.
So it presented with the diabetic ketoacidosis also.
Yes, like if patient diabetic ketosis, there should be some underlying infection should be there. Yeah, like we did CT. Dr. Sudhir, can you read the CT for us?
This is actually portal venous phase. The liver and everything seems normal. Stenting was done, and the pancreas appears bulky, and there is a infected collection. That is poor enhancement with air packets is seen anterior to the pancreas. So it's a case of pancreatic pseudocyst with or walled off pancreas with secondary infection.
Like, can you say about the cyst wall and all, like if it is matured or not?
Cyst wall it's irregular only, but after 4 weeks,
Yes, like it is not mature.
yes, after 4 weeks only,
Yeah.
the wall will be formed.
So we made a diagnosis of infected necrotic peripancreatic collection with diabetic ketoacidosis. Like Dr. Jagan, what are the management options available now?
We usually follow the step-up approach, initially with the percutaneous drainage, and then if it's, we'll collect the sample, send for culture. According to the culture, we start the antibiotics. But before culture comes, we start the antibiotic. We don't wait for the culture. And then if it's not improving, we can plan for endoscopic drainage. And last option will be surgical drainage. Usually surgical drainage is served for more after 4 weeks. We don't intervene before 4 weeks. We wait till 4 weeks. We can pull to multiple catheters if single catheter is not draining properly. And last option will be necrosectomy. That is usually done 4 to 6 weeks.
Yes.
Once the patient
Like if the cyst wall is matured, we have either a surgical or endoscopic options are there. Since cyst wall is not matured, we have only one option of interventional radiological procedure. We likewise doctor told, like there is usually a step-up approach. Start an antibiotic, not responding, percutaneous endoscopic drainage, whichever is feasible. Then there is poor response, go for a minimally invasive necrosectomy.
Yeah, regarding the
Dr. Rabi, role of endoscopic drainage, when will you do? Plastic versus metal stent, when will you avoid?
That's right. The role of endoscopic drainage comes when we see the patient's sepsis is worsening. By 3rd week and 4th week, if the infection part is worsening, and we have to first wait for the cyst wall to settle, and then to decide regarding which site and from where to put the catheter to drain outside, and which type of the stent has to be used. If the patient has a collection on the right paragolic gutter or it is away from the stomach, it is percutaneous. And if it is associated in the near to the lesser sac, that can be easily seen through your stomach wall or the gut wall, and it is less than a centimeter gap, usually we go by endoscopic drainage criteria. And then if there is a large pseudocyst or infected collection, there is a connection with the main pancreatic duct, we will be even putting a pancreatic duct stent that would drain the infected collection. So whether to go for the plastic stent or the metal stent, it depends upon the amount of necrosis or the collection inside. If it is clean, pure collection, then we'll be going for a plastic stent. If it is more debris, more later on stage, if they require a endoscopic necrosectomy, we'll be going for a metallic stent. So in metal stent placement, that could be a conventional method, and there is a single step lumen aposic metal stent placement can be done.
Yes. Likewise, like when the cyst wall is matured, usually after 4 weeks, endoscopic drainage can be done. Like if the size of the cyst is less than 5 centimeter connected with main pancreatic duct, we can go for a transpapillary drainage. Otherwise, we go for a transmural drainage, and the distance between the gut wall and the collection should be less than 1 centimeter. Coming to the stents, plastic versus metal stent, likewise he told, like more debris, go for a metal stent, less debris, go for a plastic stent. Both are equally effective when it is less debris. So like conservative approach, and what is the procedure, like if you have seen a CT and the CT shows there is a air pockets and gas bubbles in the pancreatic collection, and what will you do? What is the current guideline says?
Previously, we used to do FN aspiration and everything to check for any infection, but these days we are not doing those things. Only directly we are doing CECT and on percutaneous drainages, and only we are following this.
Yes, as of recent update from ACG 2020-24, likewise Dr. Sudhir told, there is no need for CT aspiration. If CT strongly suggests there is gas bubbles inside the pancreas, then directly start an antibiotic if follow the step-up approach. Dr. Jagan, what is the timing of cholecystectomy in this patient?
In case of acute biliary pancreatitis, with mild cases, we do before patients getting discharged so that we can avoid a recurrent pancreatitis and readmissions. In case of severe pancreatitis with ICU admissions, we generally do in the same sitting. We wait till 6 weeks, 4 to 6 weeks. Then we evaluate and then we plan. Because if patient develops any infected necrosis or any other collection, we can deal it together actually.
Yes. Mild cases, same admission. Patient is severe and with organ failure, delayed, and it can be done on the next admission. In these patients, cholangitis ERCP is done, and there is a infected necrotic pancreatic collection, and we did pigtail and we sent for the culture. Like you see, the patient is having Klebsiella pneumonia, which is multi-drug resistant organism, which is only sensitive to tigecycline and also sensitive with Elorus. So we started both, and patient improved significantly. And for the take-home message, fluid resuscitation is most important. If the patient presents within first 48 hours, if the patient presents delayed, aggressive fluid resuscitation should not be done. Moderate fluid resuscitation at the rate of 1.5 ml per kg with ringer lactate is preferred. No prophylactic antibiotic should be given, and only enteral nutrition through oral is preferred. If the patient not tolerating oral, you can prefer NG or NJ tubes. Emergency ERCP within 24 to 48 hours should be only in those with cholangitis. Other cases without cholangitis, we can wait still next admission. Cholecystectomy in the same admission for mild cases. For severe cases, we can wait. We can do after 6 weeks. Thank you.
Yeah, that was very comprehensive coverage. My only concern is, like, whenever a patient acute pancreatitis is referred to, is already 70% of cases would be having antibiotics. So that will increase the risk of fungal infection, gram-positive infection, resistant infection. So please avoid day 1 or day 3 of acute pancreatitis, avoid antibiotics.
First 2 weeks, the chance of infections are very less. Unless there is a proven culture, there is no need for an antibiotic. This way we can prevent antibiotic resistance.
You could see multiple stones here, and they are all faceted. So whenever you pull out a stone and there's a facet there, it always means that there's some other stone upstairs. So make sure that you really clear the gallbladder, CBD, completely. Otherwise you'll miss one stone inside, and they remove the JAGAN will remove the gallbladder. You'll come back again with cholangitis. I think whenever you find one faceted stone, it's always important that you make sure you clear entire CBD. I think you should do a occlusion cholangiogram, make sure there's nothing there. And if you have multiple stones, it's always better to put a stent and come back. Even if you operate the next day, it's okay. You probably can take out the stent after 2 weeks.
Yes. Any doubts? very difficult question, sir. Like we have to counsel them, and we have to tell the risks. And like for few patients, those without stones in the gallbladder, actually we can wait, I think so. And with the stones, it's better to go. And they are like one thing, like if you put the stent, then we will be in a trouble actually. We have to remove the stent, and patient is not willing to remove the gallbladder. That's a very difficult, tricky situation actually. And then that time, like very difficult for us also, sir. So, still, yes.
Sludge is one of the important cause for acute biliary pancreatitis, which is easily missed actually. Patient with have GB minimal sludge will be there, and he has LFT derangement, but the MRCT will be normal mostly. In those cases, if you do a US or you aspirate the bile, you can see microliths. And the sludge is one commonly missed, and it's not commonly properly referred to a surgeon actually, because they think sludge will deal with UDC, and mostly they come with recurrent pancreatitis again and again.
Sludge, microlithiasis is still controversial topics. Yes, sir.
US and the aspiration of the bile and send for analysis, that's very
Yes,
important.
like with spyglass and all, now we are finding stones, sir. Those missed by MRCP, those stones are all we are finding at the US, and the spyglass are able to see the stones. Yes, sir. Okay, with no further discussion, we'll close the session and we'll go for.
Thank you, sir, for this wonderful panel discussion.